Hi everybody, Ziv Simon here. I'm a periodontist in Beverly Hills, California. Welcome to an Osteo News webinar on the best flap designs. And I practice full-time with my partner Dr. Ari Rosenblatt in Beverly Hills. We've been around for some time now, and together with our team, we practice the full scope of periodontal and implant surgery and other treatments. At the same time, we very heavily document what we do. We created a tremendous database of different types of techniques, and that allowed us to create courses and different training programs for dentists. Last year, I launched my teaching brand called Surgical Master, and you can find the handout, the actual slides for this lecture on the website surgicalmaster.com. Basically, you'll opt in, add your name and email, and you'll get a link to download the actual slides. So this will be available for about 2 weeks. And if for whatever reason you're watching this later on and this particular presentation is not available on the website, then still opt in and send me an email. I'll be happy to forward it to you. Now, generally speaking, placing implants can be sometimes tricky because you have to be very conscious about the anatomy and the position of the implant and taking into account different surgical and prosthetic considerations and aesthetics. And you really have to get it perfect in there to get a good result. And when I work with dentists in different training programs, a very common question is, what is the best flap design when I place an implant or when I uncover? And really, this is part of a few factors that will allow you to achieve success with implants. The first part is a proper extraction and implant site development with bone that is in good quantity and quality, creating good soft tissue, which is a health benefit but also improves the aesthetics, and having accurate implant positioning or placement. And when you have all four components, you are very successful in implant dentistry. Now, this presentation focuses on only one aspect of the soft tissue. And when we talk about soft tissues around implants, you'd like them to be in good quantity and quality, but also develop surgical skills that will allow you to handle the tissues carefully, and good flap design is part of it. Now, if the tissue around your implants is of poor quality and you don't handle the tissues properly, you may start seeing side effects like recession around implants, even bone loss, and implant failures. And really, this is a problem because when it happens, sometimes failure is inevitable. And I believe this is preventable. It has to do with treatment planning, has to do with focus on the soft tissues. And I hope this presentation is going to be helpful to you for this aspect of implant treatment. So in today's webinar, I'm going to talk about the different flap designs for implant surgery. That includes placement and uncovering. And try to answer the question, what is the best axis? Now, when you're dealing with an immediate implant placement, your tissue axis is already defined. What you see is really what you get, and if you plan this case properly and you place your implant accurately, you can get a very good result, and you will be able to preserve the initial tissue. So when we talk about flap designs, we are dealing mostly with the healed side, where you have some options. You can choose between end reflecting a buccal flap and a palatal flap in this case, or you can choose a crestal incision that is more to the palate. Now, you can also preserve the papilla on both sides or one side alone, or go with a punch approach, and also a variation that is called the half punch approach that I'm going to describe later on. So we have some options in terms of our flap designs. And really, what is the best approach? Now, it really depends on how much tissue quality you have, how much quantity. Sometimes you have actually too much tissue. And this is a very important factor in how you handle the tissue and your flap design. Now, the tissue quality is important, but it's also important how it relates to where the implant is positioned. You may have great tissue, but it's not where you need it. So you have to factor in the ideal implant position and also your treatment protocol. If you're placing an implant in a 1-stage or a 2-stage, that will determine a completely different flap designs. So your flap approach depends on a few factors. Now, if you have a dream patient like this one, with abundance of bone and abundance of tissue, naturally, it'll be great to choose a punch approach. And my criteria is having a minimum of 2 to 3 millimeters on the buccal and palatal aspect of the site to allow me to choose a punch axis, which is obviously more than enough in this particular case. But let's take a more realistic scenario. If you have those 2 to 3 millimeters, you can very carefully place your implant in the ideal surgical and restorative position. And if you follow this criteria and have enough tissue quantity and quality, your healing from a soft tissue perspective is going to be very good. So when we talk about flapless implant positioning, your patients will have less intense pain and also for shorter periods of time. So there are definitely advantages when you choose a punch axis. So this type of approach is very commonly discussed and shown and presented, but we really talk very little about how does it actually work. So when we talk about the punch axis, we're dealing with a circular incision that can be achieved in 3 ways, either with a blade or using a dedicated punch tool or a punch drill that connects to your handpiece, which is relatively simple. The more important question is, where do we create the punch axis? And one way is to use your existing surgical guide and use the marker technique, use a denture, a pressure point marker through the guide, marking the implant site, the soft tissue, and then creating a circular incision around your marking. And then you have soft tissue access or a punch axis to place your implant. So this technique, it works very well, but sometimes we have a problem if you don't hold your marker in the same trajectory as the implant trajectory. What is going to happen? You will get the wrong marking. Now, more on a technical note for the marker technique, the marker diameter is 3 millimeters. So you'll have to add X millimeters from the center of the marking, and this is based on the implant diameter that you're placing. So once this circular incision is made, you can use an Orbe knife to remove the plug of tissue and continue with your implant positioning. So before you decide on your punch approach, look at the implant site very carefully because it can be tricky. The soft tissue profile is not in one dimension. So it'll be misleading for you to look at the implant site only from one angle, either buccal or occlusal. You have to really look at the big picture. So one way that helps me is first to identify the mucogingival junction and then see where does the soft tissue transition from occlusal to the buccal and also to the palatal. And then I can recognize the zones that I can work with and make a decision in regards to the punch axis and if it's appropriate. So it will help you to use your surgical guide and place it in the patient's mouth. Since this is a computer guide for computer-guided implant placement, we can use a punch tool that has the same diameter as the tube in the guide. So it'll be relatively simple for you to place the punch inside the tube and create the circular incision that will correspond with the implant diameter that you're placing. So this type of approach is called guided punch access because we're using a computer guide, and that will allow you to perform a simplified procedure while your patient is benefiting from a faster recovery and less pain because of the minimal trauma, and it'll also allow you to get a good aesthetic result. And we're looking at a photo with the provisional. So be very good about analyzing your surgical site, not just from the bone aspect, but also from a soft tissue perspective and the different transitions in the line angles of the soft tissue, determining what's buccal tissue, what's occlusal tissue. And the guided punch approach is going to be also very helpful in creating an accurate circular incision. And unfortunately, you will find out the exact punch position only after you remove the guide. And it may be in a good position, or like in this case, the tissue was deficient and I didn't have enough good tissue to the buccal aspect of my punch axis. And when I thought about this problem quite a bit and was a little bit frustrated with it, the solution actually came from my assistant Patti. And I call this technique the Patti technique, not the Patti, because she came up with a great solution. She said, why don't you take a disclosing solution, use your punch tool, dip it inside the disclosing solution, and then create a little marking. Let's call it a stamp. And don't punch the tissue, only mark it, only stamp it, then remove the guide and see where it lands. And I thought this was a really great idea, so I call it the Patti technique. And when we use our computer guides, we use our punch dipped in disclosing solution, wherever you have a doubt or you have some questions about it. And you create a little marking on the tissue. So in this case, there was some deficiency on the buccal, and I decided to make a mid-crestal incision in order to preserve some of the tissue, reflect the full thickness flap, and then punch the residual lingual tissue. So this approach is called the half punch technique. And then you can proceed with your osteotomy while preserving good tissue on the buccal. So the punch and the half punch techniques, they're relatively simple. It creates a better patient experience. And you really have to be selective and very cautious when you go with a punch. And my experience is that most implant sites are deficient in soft tissue and don't allow us to choose a flapless approach. So it is sometimes tempting for obvious reasons, but I find myself every once in a while regretting not preserving more tissue on the buccal aspect of the implant. So the punch axis is not ideal when you're dealing with poor tissue quality and quantity. Actually, sometimes if you have too much tissue or tissue excess, that's also not good in terms of the punch because you're dealing with a very deep placement from a soft tissue perspective. If you're planning grafting at the same time or at any point in the treatment, you'll have to use some type of flap approach. And definitely when you're planning a two-stage implant protocol, you will have to choose some type of flap to place the implant and then keep it submerged. Now, in my opinion, and also my experience, is that most cases will require some type of flap because we are most of the time struggling for tissue. The tissue is deficient quite often, especially in the posterior mandible. So you may have adequate bone, but like in this case, I would choose a flap approach with a mid-crestal incision and a full thickness flap to the buccal and the lingual to preserve the maximum amount of tissue. That will allow me to place the implants, and once the flaps are sutured back around the healing abutments, following a healing period, the implants and eventually the implant restorations will be surrounded by good tissue. That is very advantageous. Now, many times our periodontal patients that are losing teeth will present with poor tissue quality. And this is a patient that needed several extractions, some of which were in the aesthetic zone and needed a significant ridge augmentation with the titanium mesh, followed by placement of several implants. Now, once the ridge was augmented, and was augmented significantly because this patient lost a lot of bone and tissue due to periodontal disease, The residual ridge had very good bone volume following the augmentation. But if you look very carefully, the tissue under the provisional bridge was very inflamed. The tissue quality was poor, and there was some vertical deficiency, but very good bone thickness. I planned the position of the implants with a computer software, and when the time came to place the implants, I used the marker technique through my surgical guide, and I wanted to see where those marks end up. And if you look very carefully, you'll see that the marks end up to some extent on poor tissue quality, deficient tissue. And for that reason, I decided not to use a punch access, but to use a full thickness flap to preserve good amount of tissue. So my flap design consists of a crestal incision that is more to the palate and two vertical releasing incisions. One is meant to preserve the tissue between the central incisors. This is number 8, and this is a future number 9. So I wanted to preserve this tissue and give a better chance for a good aesthetic outcome while having good access to the ridge. So here is our incision outline, a crestal palatal incision and two vertical releasing incisions. And once the full thickness flap is reflected, you can see a very significant ridge augmentation that was actually done by a colleague of mine. And a great platform, a bony platform for the implants. Now, once I place my surgical guide back in, and you see the flap laying against the guide, keeping it open, I can now use a completely guided implant placement protocol that consists of creating the osteotomy through the guide and also fully guided implant placement, meaning the implants are placed through the guide to their final position. Now, the approach that I used also gives me the flexibility to choose between a one-stage and a two-stage treatment protocol, and that is depending on the insertion torque values that were very good in this case. So I proceeded with a one-stage protocol, suturing the tissue around healing abutments, preserving the majority of the tissue, and suturing in a way that the flap drapes around the flared healing abutments. And then adjusting the provisional bridge, re-cementing it, waiting a healing period of about 3 months until the implants are definitively restored. And you can see that the soft tissue profile is very pleasing in terms of the tissue quantity and the quality, especially considering where this patient started from with a lot of tissue and bone deficiency as a perio patient and getting a very adequate result. So using a full thickness flap with a palatal access allows you to preserve the current tissue, allows you to bypass poor tissue quality, and also gives you the option to choose between a one or two stage treatment protocol, and that's totally up to you. Now, the aesthetic zone is always more challenging. You have to spend more time planning and making good decisions because these would have serious implications and it's all visible. So you have to be very good about the decision making so you get a great outcome. This patient came in with a fractured number 9, a central incisor. It was obviously fractured on the radiograph. So when you see this presentation, you can already expect a very significant bone destruction, and you can pretty much plan on a delayed placement protocol. So once the tooth is extracted, you can plan on a full thickness flap in order to clean out the infection and also allow you to graft the site for a future implant. So in this case, I decided to preserve the interproximal tissue between the central incisors and proceed with a vertical releasing incision on both sides. And for access reasons, I decided to reflect a full thickness flap to make the bone and membrane handling easier for me. And you can see that this site has no buccal plate whatsoever. So I did graft the site with allograft material, used the membrane to contain the graft on the buccal aspect, and sutured the vertical releasing incision with no attempt for primary closure on the extraction socket. You're looking at a collagen plug right on the occlusal surface of the socket. So the patient healed very well, but the site was still deficient in the horizontal dimension. So I had to make some decisions what type of flap approach I'm going to use in this case. One of the options that you have that will help you preserve the interproximal tissue between the adjacent teeth and the future implant restoration is a papilla sparing incision outline. And by creating two vertical releasing incisions that are somewhat diagonal, again for access, you can reflect the full thickness flap, place your implant, and that will allow you to graft more bone and even use a membrane. So you would make your incision more to the palate and place two vertical releasing incisions. And the question is, how close are the vertical releasing incisions to the adjacent teeth? How much of the interproximal tissue can you really preserve? So you have to preserve enough so the tissue doesn't slough off, but you can't leave too much, otherwise you're limiting your access for your implant positioning. So it's a really fine balance between the two. So in this case, I looked at the diameter of the planned implant, which was 4.3 millimeters, and that was the distance between the two vertical releasing incisions at the coronal aspect of the flap. And naturally, as we go more apical, since those releases are diagonal, that will allow me space to place bone on the buccal surface of the implant and place a membrane to contain it and also close in primary intention. So for this case, I waited about 3 to 4 months for the implant to heal, and you can see from the occlusal aspect that the tissue and bone are still deficient to some extent, and you can correct this with your uncovering. So the uncovering process also has some benefits, not just to uncover the implant, but also to create some additional tissue. And the flap approach, and you may notice that the flap approaches are getting smaller and smaller as we move forward with our implant sequence. The flap would include a palatal full thickness incision with two vertical papilla preservation incisions slightly to the buccal, not very long, uncovering the implant, displacing the tissue more to the buccal, and allowing it to heal. And at some point, you can even change the healing abutment to a taller one, flared one, to allow for tissue maturation, and when at the right time, impressions can be taken and the implant is restored. And you can tell that the implant restoration has symmetrical tissue levels and also good tissue quality. And I believe this is due to the staged approach, where every time I had a surgical opportunity to augment bone, and I could also manipulate the tissue in a way that was advantageous for the final outcome. So when you're considering a papilla preservation incision outline, it has an aesthetic advantage, like I showed in this case, but you're also risking scarring. So take this into account. So you'd like to have very good tissue approximation and good suturing technique. And the other advantage, it allows for additional grafting. So try to be very selective in regards to your flap design. Each flap design should have a rationale. You should have a reason why you're choosing it. It's not a random decision. In this case, my goal was to preserve the tissue on the adjacent teeth, so I chose the same flap design, placed the implant. I should have probably grafted at the time of placement because when the time came for uncovering, the tissue contour was very deficient. Now, as I showed before, you still have the opportunity to improve this at the uncovering procedure. So you can still use the papilla preservation technique, making a palatal incision, a full thickness incision with two vertical releasing incision, preserving the papilla on each side, slightly extending it to the buccal, and then reflecting a full thickness flap. So the first thing that you'd like to do is make sure that the implant integrated. Okay, that's the key. And once you verify that, you can very carefully use tunneling instruments and tunnel the area that is to the buccal of the implant, right in here, creating a small space that will allow you to place a soft tissue graft, in this case an allograft, into the pouch that you just created. So the graft is inserted into the pouch very carefully, and that will augment the buccal contour around the healing abutment. And ultimately, this will improve the tissue profile, the emergence profile of the final restoration when the tissue heals. So the improvement in the tissue quantity is a function of displacing some of the palatal tissue to the buccal and preserving the tissue, and also the grafting. All of these made a difference in a good aesthetic outcome. And you can read the details in this article that was published a few years ago in the Journal of the California Dental Association. So to conclude this presentation, I try to help you answer the question, what is the best flap design for implant surgery? I showed you several options and different indications, and there are certainly different ways to solve the same problem. So what I'd like you to consider when you're planning your flap for your implant procedure is the tissue quality and quantity and how it relates to the implant positioning. Do you require any type of bone or soft tissue grafting, and also the treatment protocol in terms of 1 or 2 stage approaches. If you're looking at this case, you're seeing a deficient ridge where the mucogingival junction is on top of the ridge. So you have a few options. You can either use a lingual crestal incision and then mobilize the tissue to the buccal and gaining some more attached tissue and place your implant. And option number 2 would also be a soft tissue graft as a preparatory procedure before your implant placement. So you have options. I chose to use a free gingival graft and augment the soft tissue contour of the ridge. And once this healed, I was able to place my implant, still preserving the tissue with the full thickness flap, and getting to a point where the implant has ideal soft tissue around it and is ready for impressions. So really the best flap design is the one that creates good tissue quality and quantity. It matches your treatment protocol. It allows you to place the implant in the right position in a way that it can be properly restored with a good aesthetic outcome. And there are definitely more implant flap designs that I can share with you, and I will share with you in the future, because we need to address sometimes very difficult and challenging situations, like this one, where a patient presented with a severe resorptive process around the central incisor. Now the choice is yours in regards to your flap design, and I did whatever I needed to do to remove this tooth and graft bone and create a good implant platform that allowed me to place an implant in a good position and ultimately restore the implant with very good aesthetic outcome. I hope this presentation was very valuable to you when you're planning your flap designs for your implant surgeries, and that now you can look into the different factors that determine the best flap design in a particular case. You can download the handout for this presentation on my website, surgicalmaster.com. You can opt in, add your name and email, and you'll get a link to download the presentation, and also a document that includes all the different flap designs that I described to you in this presentation. So thank you very much for your kind attention. Thank you to OsseoNews for this opportunity to present. I hope this was helpful, and I look forward to seeing you and working with you in the future.